Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is a question review on neoplastic and hyperplastic skin disorders and dermatological emergencies.
Okay, let's do some questions. An 80-year-old Caucasian lady presents with a 6 months history of a 2 centimeter pearlescent nodule over her nasolabial fold. Given the likely diagnosis, what is the most appropriate treatment option? A. Camouflage, B. Curettage, C. Cryotherapy, D. Mohs surgery, E. Topical steroid. Hopefully this is ringing alarm bell in all of you that this is a classic history of somebody presenting with a BCC. You have an 80-year-old lady who has white skin and has got a relatively slowly progressing, is a 6 months history of a small 2 centimeter, and the key really is the pearlescent nodule on her nasolabial fold and the location of it. So hopefully you have got the BCC, and as you remember, the gold standard treatment for excising the BCC is the Mohs surgery. Option A is completely irrelevant. Doing camouflage or makeup is not going to take the problem away. Curettage and cryotherapy are potential options. However, they're not the gold standard and the first line treatment that you should be offering the patient. And topical steroid won't make any difference in the treatment of the cancer. So the correct option is option D. So let's do some questions. A 50-year-old Caucasian man presents to his GP with a rapidly growing dome-shaped nodule over the last 2 months on his left earlobe. On examination, there is a central keratin-filled plug on top of the erythematous surrounding skin. What is the most likely diagnosis? A. BCC or basal cell carcinoma, B. malignant melanoma, C. keratocanthoma, D. cellulitis, E. eczema. So reading this vignette, there are a few things that should hopefully lead you towards the correct diagnosis. A. The fact that this is a middle-aged Caucasian man. B. The fact that he's presenting with a rapidly growing dome-shaped nodule for a period of 2 months, which is relatively a short period to have the symptom. And finally, the area that this is being affected, which is the earlobe. And the last point to consider is the way that the lesion is described in the question vignette. So it has a central keratin-filled plug on an erythematous base. So reading all of this, if we go through all of the options, BCC is not going to be the correct option because this is not classically describing your pearlescent nodule. Malignant melanoma is not going to be the likely option because this is describing a very rapidly progressing case and specifically is saying that it's filled in with a central keratin-filled plug on an erythematous base. As a result of that, cellulitis is not going to be the correct option. He's not complaining of any temperature or infective symptoms. And eczema is completely irrelevant in here because this is not the definition of an eczema. Eczema doesn't cause dome-shaped keratin-filled plug. So really, by definition, even if you don't know the exact correct option by rule of exclusion, you should be getting to option C, which is keratocanthoma. That is the correct option in here.
Now let's try a question. So a 40-year-old Caucasian lady presents with a 4-week history of pigmented 2 centimeter lesion on her cheek with asymmetrical border. Which of the following factors is not relevant in the assessment for a malignant melanoma? So our options here are colour variegation, border irregularity, diameter greater than 6 millimeters, asymmetrical, or discharge from lesion. So this question is asking you to remember the ABCD assessment of a melanoma, and you'll remember that all of these are present in that score, aside from looking for discharge from a lesion. However, that is something you would want to make note of and investigate further separately, but it isn't part of the ABCD score. So let's try a question. Which of the following is a common histopathological finding in SJS? So our options are acanthosis and hyperkeratosis of the epidermis, hypocellular dermis with abundant collagen production, dense infiltration of eosinophils throughout the dermal layers, separation of epidermis at the dermo-epidermal junction, and unilocular bullae formation in the subepidermal space. So the correct answer here is option D, which is separation of the epidermis at the dermo-epidermal junction. It's really important to try and remember histopathological features, especially in dermatology for the Part 1 exams in particular, as these may well come up in the exam. So let's try a question. Which of the following can help differentiate TEN from SJS? So our options are degree of epidermal detachment, presence of target lesions on the skin, involvement of mucous membranes, age of the affected individuals, and association with viral infections. So the correct answer in this case is option A, degree of epidermal detachment. You'll remember that the thing that differentiates SJS from TEN is the fact that in TEN, more than 30% coverage is seen of the affected skin. Now for a question. So a 40-year-old Indian lady presents to her GP with a 2-month history of worsening hyperpigmented, thickened, velvety skin over the back of her neck and armpit. She has been found to have a HbA1c of 60. What is the likely dermatological diagnosis? So our options are eczema, psoriasis, lichen planus, Acanthosis nigricans, or melasma. And so you'll recall from this presentation that Acanthosis nigricans is the most likely answer in this case. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.